Good morning, dear colleagues. Today I am honored and pleased to co-chair this session with Professor Juan Granada, well-known interventional cardiologist, CEO and President of Cardiovascular Research Foundation. We also have the privilege to discuss the different subject of this session with esteemed panelists. Professor Van Bardeloben from Germany, Structural Imaging and Interventionist Director of Mainz Heart Valve Center. My friend, Professor Nadam Hajlewi, interventional cardiologist, head of the cath lab of our cardiology department of military hospital, Tunis, Tunisia, and Professor Walid Ben Ali, son of Tunis, Tunisia, who supported us in getting this session finalized. Now, expert in interventional cardiology, director in Montreal Heart Institute Structural Valve Center. So this session will focus on mitral regurgitation repair. We are more than happy and grateful to welcome our speakers and panelists, as you have the chance to listen to the best of the best experts of the world from USA and Europe. The topic will be, is functional mitral regurgitation an indication for transcatheter edge-to-edge repair or for valvular repair surgery? As you know, patients not treated will have 20% of mortality at 1 year and 50% at 3 years. We are having a very interesting session with two live in the box, one from military hospital and the second from USA, Piedmont, Atlanta. So, I encourage the audience to interact with our panelists and discuss together the following topics. Should we operate functional mitral regurgitation more? Can we expand the TEER indication to moderate risk patients? And finally, why is TMVI so complicated when compared to the TAVI is one? Now, I have the great pleasure to give the floor to our first speaker, Professor Nadam Hajlewi.
Thank you, Professor Fehri, for this introduction. I will not give you a conference, but I will show you the live in the box already registered in the military hospital of Tunis. So please, can you start the live in the box? I am Dr. Hajlewi, Professor of Cardiology and Interventional Cardiologist from the military hospital of Tunis. First of all, I want to felicitate the board of the Tunisian Society of Cardiology and Cardiovascular Surgery for their kind invitation. It's a pleasure to show you this live in the box of the implantation of mitral clip, which was done in the military hospital of Tunis, the 19th of October 2024. This procedure was done by myself, and I was helped by Dr. Ayman Nouman, Aggregate Professor of Cardiology and Interventional Cardiologist. We worked together in the Military Hospital of Tunis. The proctor here was Walid Zouari, a great cardiologist from Lyon, and he it was our proctor for this implantation of this mitral clip. The echo guidance was done by Professor Wafa Fehri, great echocardiographist, and it was helped by a great proctor from Lyon also, which is Dr. Pierre-Yves Leroux. We felicitate both proctors from Lyon for their great proctoring. Thank you very much for your help. The patient is 76 years old. He has hypertension, atrial fibrillation, and COPD. He was diagnosed with severe mitral regurgitation. We discussed it with our colleagues from the surgery department, and they found that it's a patient with a high risk for surgery. So that's why we decided to implant a mitral clip in this patient. First step, it's the analysis of the mitral valve by transesophageal echocardiography. So here the analysis was done by Professor Wafa Fehri and with a great proctor from Lyon, which is Dr. Pierre-Yves Leroux. So as you see here, the evaluation of the mitral regurgitation in standard view showed that we have a restriction of the posterior leaflet, and essentially in the central part, so it was A2, P2 regurgitation with a great restriction of the posterior leaflet. Here, our colleagues measured the length of the posterior leaflet. Here, they measured 9 millimeter. So after discussion, we decided to implant an NT W. Why NT? Because the clip, the length of the clip with NT, it's 9 millimeter. When it's XT, the clip it's 12 millimeter. So here we have 7 millimeters. So with NT it will be okay. And why it's wide? Because the regurgitation it was a little bit wide. So in this patient, we evaluated also the surface of the mitral valve when it's open, so in diastole, and generally it has to be superior to 3.5 centimeters square. So here we measured 4.8 centimeters square. The gradient, it was 1 millimeter of mercury. Also, before the implantation, we analyzed here the pulmonary flow with, as you see here, S wave in the left pulmonary vein, which was very small, and also in the right pulmonary vein, we have a very, very small S wave. And it's very important to compare it after implantation of the clip. So generally it will increase and we will have a good S wave in the pulmonary vein. Generally, a clip, it will reduce the surface of the mitral orifice by 50%. So that's why we will put only one clip here because of the surface, which is 4.8 centimeter square. Here we will show you all the steps. So the first step, it's after the evaluation of the mitral regurgitation and the measurement of posterior valve. Here we perform the transseptal puncture. The transseptal puncture, when we perform it, it has to be done under TEE guidance. And here we have two things which are very important. It has to be, this puncture has to be posterior, so which allow us to work easily with the clip and to navigate easily in the left atrium. The two views that we use when we perform the transseptal puncture are the bicaval view and the short axis view. So as you see here, we did the puncture posteriorly and we measured here 43 millimeter, which is okay, which will allow us to navigate easily in the left atrium. After that, we have to be perpendicular to the mitral smile, and here we have two views which help us a lot. So we have the view, the intercommissural view, and the longitudinal view, which will allow us to be perpendicular. There is also multiplannar reconstruction that our colleagues, Dr. Pierre-Yves Leroux and Professor Fafeli done, and they give us the plans when we have to navigate to remain all the time perpendicular. After that, when we check the perpendicularity and it's okay, then we close the clip and we will go in the ventricle, and after that we will try to grasp the leaflet, the anterior one and the posterior one. And here we use also two views, which are the intercommissural and essentially the longitudinal view, which will allow us to do the grasping. After grasping the valves, we close a little bit the clip and we check for the gradient. Here, as you see, the gradient is 4 millimeter of mercury. Generally, we must have a gradient less than 5 millimeter of mercury, so here it's okay. And we check generally the pulmonary veins, and here, as you see, we have an increase in the S wave of the pulmonary vein. We have another thing here, which is the pigtail that we put at the beginning in the left atrium, which allow us to have an idea about the pressure in the left atrium. So as you see here, it has decreased. And after grasping and closing the clips, so we have to evaluate the residual regurgitation. And here, as you see, we have a regurgitation that almost disappeared totally. It remains a little bit of regurgitation, which was lateral to the clip. So the result is good, and the clip is stable. The pressure in the left atrium has dropped, and the S wave in the pulmonary vein has appeared. So it was a good result, and the patient improved a lot during the days that comes after the implantation. Thank you for your interesting. Bye.
Zach, Great presentation, and thank you for highlighting the most important components of the procedure. We're open now for any discussion or questions from the audience. If anybody has a question, please go ahead and stand up and ask a question.
Professor Faber.
I would like to congratulate the team of Professor Hajlawi and Professor Fehri for introducing this technique in the military hospital of Tunis. The results, as I know, because I know one patient, and this patient is a relative of mine, and his life has changed since he has had this mitral clip. So the problem now is how to encourage your team to have more patients, and how can we do to decrease the cost of the mitral clip by maybe having a larger number of patients, and maybe with all the good results, and I know that it is possible. Thank you.
That is actually an excellent question that I wanted to ask Stefan. In places in which you have to be careful with resources, and you have to properly select the patient that is going to truly benefit from the technology, why don't you just describe, based on your experience, what would be the patient population that you think it would be? I don't want to talk a guideline like class 1 or whatever, but you say, like, this is the type of a patient in which you're going to obtain the biggest benefit for the technology.
Yeah, I think we have seen a lot of the important steps to diagnose. So one of the diagnoses is, of course, to see that the patient is suffering from mitral regurgitation. We know that patients that actually have a severe, really severe MR, and the MR is influencing clinical symptoms. So we've seen the ReShape study and the Co-op study that patients that had New York Heart Association class 3 and 4 actually in the subgroup analysis had the best benefit. And we can actually see this also by the invasive hemodynamic monitoring. So if you see a V-wave drop after the clip implant, this is for the learning, then we know that the mitral was a major part in the V-wave. There's also myocardial stiffness. And if the V-wave persists and you don't reduce the V-wave by your mitral clip implant, then it's a myocardial problem and the patient will not benefit. So this is something we will learn on doing more and more procedures. On the other hand, I can only encourage to have like buying unions. This was the military hospital, and I introduced also this device to the peninsula in Iberia and also to Asia. And it's very important that you stay together and you have common buying consortia also in Tunisia, because I think with the private and the public sector, this will benefit both sides.
Yes, I think Professor Themer speaks about the cost of, it's very high actually in Tunisia, so we can't make many procedures. But we should have we should encourage all cardiology department in Tunisia to select people who have mitral valve regurgitation functional, and to have a department, reference department, and to try to speak with our national assurance to have more and more procedure, mitral clip, like TAVI.
Yeah, but actually the point is, Stefan, and I'm from Tunisia, and when I visit, I saw a lot of things. Actually, if you want to discuss better price, you have to pull all the activity in one center, because increasing the number of this center, he will have 30, 50 case volume yearly. So the discussion is not the same with the company. going to the company with a volume of 2, 3 cases, it's not the same going to the volume of 30. And let's think also even beyond Tunisia, sub-Saharan Africa can also refer to this center of excellence, if we can call it like this, all their cases, and you start to be a hub of MitraClip, one hub for not only Tunisia, but probably for the region of North Africa or Tunisia and Sub-Saharan. Like this, you have better volume. And Stefan, it's not the same. Stefan is doing 400 yearly, more or less. I'm doing 150, 200. The discussion is not the same. So the more you do, the better it is. Now for the question of Juan, if I'm a surgeon, I know it's a little bit difficult, and surgeons are pushing and are fighting against MitraClip. And I'm a surgeon, but I'm a believer of transcatheter. I'm doing around 90% of my activity is structural now. To make it easy to Tunisian, all functional mitral regurg, if there is no revascularization, it's better to send this patient to MitraClip, and you will increase your pool. This is our approach in Montreal Heart Institute. So to make peace with surgeon, we decide this algorithm. If you have no revascularization, FMR, send it to CLIP. If there is DMR, degenerative mitral regurg, with high-risk patient, send it to the MitraClip. This simplifies the approach. It's not the best approach. It's not a lot of guidelines based, as Juan said, but it's practical algorithm. I don't know if you agree with this or not.
I totally agree. So what we did is set centers of excellence. So in the beginning in Germany, there were only 10 centers. It now increased. We have only almost 200 centers in Germany doing MitraClip. But if you have a volume above 40 per year, it's also much easier to increase the program to tricuspid and to other things that we see now, like replacement. It's very important to have in one center structural experience and structural excellence, because these procedures all interact with each other. And this makes a lot of things easier for you. So I think I agree with Walid that centers in the beginning have to be there, and then you can have a snowball system, as we call it. Of course, you have no snow here, but you can, dune balls then, sand balls. But you will increase the number of centers over time. But this gives you higher quality and also better prices.
I think.
Thank you, Professor Habib Thamer. I want to now answer you with local data. We started already negotiation with the authorities, and we are now advanced in our negotiations, and they promised us that they will give a reimbursement for a little number of patients the first year. So it will be probably between 10 and 12, which allow us to do at least one per month, and it will be totally reimbursed by the public insurance. And to be honest, many of our colleagues of the other department were agreed to send their patient for evaluation and to prepare them for the implantation when the reimbursement will start. So we are advanced, and I hope that in the upcoming month we will have reimbursement for MitraClip in the military hospital of Tunis.
Professor Morali, a question.
Thank you very much. My opinion is to build such a program, but because it must be a program to install, you have three requests. First, the number of procedures. So to have one site of excellence, I think it's a good thing. When we discuss with the Minister of Health and Social Minister, we agree to have one center for 3 years to be the only center who do that. Why? Because I think for the intervention cardiologists, we need a minimum of a number. The second thing is the expertise of echocardiographist. And I think we have to work in this point, because the echocardiographists must have an expertise, but must have an experience with the patient. It can be good, not good. It's with the number and with the proctor that can be progressed. The third problem we have, I think it's the same problem in the world, is the disponibility of anesthesiologists and we must have an anesthesiologist in the cath lab and the disponibility of one echocardiographist. So it's my question. Now, some centers in the world are working with intracardiac echocardiography. I think it's so far to be able to, and it isn't safe, I think. For ETO, mini-invasive ETO, is it something that can be used here in such a long procedure or not?
So I think in mitral you don't need ICE, to be honest. You can do it with TOE, which is much cheaper. There are isolated cases. Even we, as a high-volume center, only do less than 3% ICE cases. It is very, very helpful if you have a lot of pre-operations, but only in tricuspid, I think there's a use.
We're going to move into the next talk by our good friend Agustin Koisen. I'm going to rephrase it. If there is a place, there's always a place for surgery, but I hope that actually he talks about what is the role of surgery in right now in relationship with the M-tier.
Thank you. First of all, I would like to thank the Executive Committee for the invitation. Of course, I'm not Thomas Modin, and I'm not a cardiac surgeon. I'm doing mainly imaging and echo. So I hope I will try to get the answer at this question. I have a pointer right here. That's perfect. So my conflict here. So first of all, when we speak about secondary MR, about functional MR, we need to keep in mind that we don't have only one mechanism, but we can have patients with ventricular functional MR with poor LV function. We can also have patients with ischemic MR, with ischemia of the papillary muscle, most of the time of the posterolateral wall, leading to a restriction of the posterior leaflet. And we can also have patients with atrial functional MR, meaning a normal ejection fraction, but a huge and dilated left atrium. Of course, you all know that the concept of functional MR is a concept of the disease of the left ventricle and a problem in the balances between closing and tethering forces. And you also know that we have an association with secondary MR and survival and outcomes for each grade of MR severity, meaning that even patients with moderate SMR have a poorer prognosis than patients with mild secondary regurgitation. And what about the treatment? Of course, we have patients with heart failure and reduced ejection fraction, meaning that the first treatment is to propose these 4 medical drugs. It's a class 1 recommendation. We have new drugs like gliflozins, but also, if the symptoms persist, we need to consider this therapy as a class 2 recommendation. It's perfectly highlighted in the latest European guidelines. What about the treatment also? If the patient has symptoms and severe secondary MR despite treatment, we need to discuss within the heart team if the patient is appropriate for valve surgery. It's a recommendation from the ESC. If yes, you can propose surgery, but you will see that we have more and more data suggesting to propose other therapies. And if we think that the patient can fulfill criteria suggesting an increased chance of responding to a TEER, we can propose a edge-to-edge repair, a transcatheter edge-to-edge repair, or selected other valve therapy in selected patients. So we mentioned that it's mainly a disease of the left ventricle, and this is why a couple of years ago they tried to treat the left ventricle. They proposed the core cap device, which was basically a socks around the left ventricle, but also the coapsis implant with a pad to reduce the size of the left ventricle. Unfortunately, all these techniques failed to prove a benefit compared to a medical therapy. And there are ongoing trials, but with percutaneous devices trying to reduce also the size of the left ventricle. The first trial trying to assess surgical replacement published in New England Journal of Medicine 8 years ago was a randomized controlled trial where they compared repair and replacement, surgical repair and replacement. They found no difference between the two groups at 2 years regarding death and outcomes. But if we look at the recurrent MR, rates of recurrent MR after the operation, you can see that patients within the repair group had higher rates of reintervention and recurrent MR, meaning that we would need probably to replace rather than repair the valve in these patients. The second trial, published the same year in the same journal, randomized patients to either CABG or CABG plus mitral valve repair. And they found, once again, no difference between groups regarding deaths and MACEs, meaning that probably we should only propose CABG and don't propose a repair, concomitant repair in this population. But the latest trial and really important publication presented this year at the ESC Congress, the Matmata trial, and Stefan was part of the trial. They included patients with secondary MR, moderate secondary MR, poor LV function, but function more than 20%, symptoms, NOHA class greater or equal to, and patients were randomized in 16 centers in Germany, a 1:1 ratio to either TEER or surgery. It could be repair or replacement. The first endpoint was efficacy. And if we look at the efficacy, which was a composite of death, heart failure, mitral intervention, assist device implantation, and stroke at 1 year, they found no difference between the two techniques regarding efficacy, albeit a trend toward better efficacy in the TEER group. But if you look at the safety, you can see that major adverse event within 30 days occurred more frequently in the surgical group than in a TEER group. It was significant, but keep in mind that it was a combined endpoint of several outcomes, including new onset AFib, including bleeding, including something that, of course, are obviously related and more frequent in surgical techniques. Finally, if we look at this, you can look at, on the left, at the severity of secondary MR at 1 year, and you can see that in the surgical group, we had higher rates of 0 or 1+ residual MR at 1 year compared to TEER, and no difference regarding NOHA class. We had this patient in Lille Hospital a couple of years ago. You can see this patient with very poor ejection fraction, prior myocardial infarction. You can see the ischemia of the posterior lateral wall and a restriction of the posterior leaflet. The patient was not suitable for surgery, and we discussed this with our surgeon. You have this 3D evaluation. You can see pretty well using transillumination the restriction of the posterior leaflet and the tethering and the hole between P1 and P2. The problem with that is not all patients are suitable for mitral TEER. And for instance, this patient had a very short posterior leaflet, less than 5 millimeters. So we were not able to propose a TEER in this patient, and we proposed a TMVR with a Tendyne device, which was the only one available at this time, and the only one with a CE mark. But keep in mind that it's a transapical approach, which is not so evident in patients with poor ejection fraction. And this new technique, this two-tier therapy, has been compared between TMVR and MT in secondary MR patient. It was a propensity mass comparison between choice MI patient and Euro SMR patient. Sebastian found that TMVR was associated with superior reduction in MR severity, superior in symptomatic improvement, a trend toward better survival for M-tier, but if we do a 30-day landmark analysis, we found no difference between the two techniques. So in conclusion, is there a place for surgery? There are less and less evidences and data that secondary MR should be treated, shouldn't be treated surgically. Surgical repair seems to be better than surgical replacement, and M-tier is equal to surgery, either repair or replacement in terms of efficacy, but is better in terms of safety, albeit this data from Matmata I exposed you. There is a place for other targeted therapies for M-tier ineligible patients. Of course, it requires further investigations. Thank you.
Thank you for this excellent presentation. So are there any questions? Professor Salma Sharfuddin.
Thanks for this good presentation. I have a simple question. I think the problem in Tunisia here is to encourage the screening and the good screening. And then how can we really encourage this?
I mean, of course, the screening for this population with secondary MR starts with echo, but also with all the heart failure specialists, with all the heart valve team. So it's really important to build this heart valve team. Regarding the screening, echo is not so complicated. What is complicated is to assess MR severity and also to assess the LV consequences. Sometimes it's too late to propose any strategy in this population. We have a session this afternoon regarding the screening process at 2 p.m., so I encourage you to come. This is one way to progress in that field.
Okay, thank you. And my second question is, I think in Tunisia we have also the problem of rheumatic disease. So my question is, in old patient with degenerative mitral regurgitation, is there any association, and how really to, there is any problem, technique problem, if there is a rheumatic and degenerative association?
Of the subarbular apparatus, this population have not been really explored in the data, but for sure they are not most of the time good candidates for a mitral tear.
So I think we need also some study in African countries and in Tunisia.
Definitely.
I think we are late. Thank you, Professor Quazen. And now we will invite Professor Van Berdeleben to speak, and the title is MTER in degenerative mitral regurgitation, results and future horizons.
Thank you very much. First, when I looked into the title, I thought I was speaking about functional disease, because most of the results and trials have been done in functional disease, as presented by Augustin. It was great pleasure that actually MTER, about 22 years ago, started with a majority of patients in the Everest trial series with degenerative disease, and actually in operable patients. If we look into the mitral valve, we see the interaction, and it's important to look at the AV valves, which is the mitral valve, of course, on the posterior side of the heart, and the tricuspid valve on the anterior side of the valve. And if we look into the different height levels, almost everything outside the chambers and the pure dilatation of the annulus is a degenerative disease. I'm well aware that in the African as well as in the Asian and Indian populations, there is still a big role for rheumatic heart disease as mitral stenosis, and we'll also address this later in this session with the replacement issue. Of course, if you have mitral stenosis and regurgitation, TEER is not a good option. On the other hand, we're able to help patients, and with the availability of antibiotics and with the decreasing influence, at least in the Western world and many parts of the world, including Eastern Europe, there will be a shift also in Tunisia, I think, in the future, to have more prolapse disease, so regurgitation disease, than stenosis. And looking at Germany, it was a ratio of 5-to-1, regurgitation versus stenosis in the 1960s. We now have a ratio of more than 200-to-1, regurgitation versus stenosis in Germany nowadays, and it's a rare situation to have mitral stenosis anymore. If we want to look now into the options for TEER, it is important to look at the anatomic suitability and also into the screening process. And I agree, of course, that echo is the main standard, but to do it before and to be very, very easy on general practitioners, it's also important to simply do an NT-proBNP or a BNP value. And if this value is above 500 to 1,000, you can further evaluate this patient. If it's under, mostly you don't have a severe mitral regurgitation, and this is a good cost-benefit ratio, at least in Europe and in Northern Africa. So if we look into the green field, this is something where you start your center. This is the straightforward anatomy. This means no calcification, no sclerosis, a well-opening valve, and it can be a prolapse. And the most simple TEER options are in the A2-P2 area where there are no cords. So this is the straightforward TEER procedure to start with if you have a limited accessibility of the device. As your experience increases, you will go to the more complex, to the yellow zone in the traffic light system, and you will treat patients that are outside A2-P2, more in the commissure. And if we go to the red zone, this is unsuitable for TEER, and we'll discuss this later in the session for replacement. So this is a staged process for you to intervene. I'm aware that you're mainly having or only having at the moment the MitraClip and the G4 iterations. It's a very powerful device. We have to know that we have an experience of more than 140,000 implants in humans so far. It's an extremely safe procedure. So mortality at 30 days is in the range of 1 or under 1%, even in a mean age of 80. And my oldest TEER patient was 96 years at the time of procedure. And the survival was more than 4 years for this patient. So these patients become 100 years now in Germany. And I heard also that you have many longevity patients here in Tunisia. If we look into the latest iterations, it's the Edwards device that is not yet available here, but you see it's a different alloy. It's not stainless steel. It is nitinol, so titanium together with nickel. And this situation allows for the system to be elastic. So it will respond to volume change, and you're also able to separately engage the leaflets, which can be helpful in a prolapse flail, where you first engage into the prolapse and then put it to the healthy region. So what is primary MR in the Western world outside mitral stenosis? Well, it's mainly fibroelastic deficiency in about 90% on the right-hand side, but it's also Barlow's disease, which is excessive tissue on more than 4 segments in the human heart. And both can be treated. How is echo looking like nowadays? And you see that imaging becomes more and more important. This is not CT. This is echocardiography in our lab, and you're doing virtual reality, and it's the same companies, NVIDIA, that are doing artificial intelligence that also help you to get these cinema-like images of the valve in the hybrid OR, in the cath lab, to actually steer your procedure. So you see a situation before, you see the cords at white spots, which are sub-millimeter, and on the right-hand side, you see a TEER implant in the middle in a degenerative disease. What about the data? Trial 2-to-1 versus the Pascal initiated by the Edwards group. We also took part in the steering committee, and the MitraClip, which was about 100 patients and 200 on the other side, so 300 in total. You can see the different usage of the clips, and as in the live case that we've seen, the NT or then the NTW, you can see that this was a major part of the devices in this trial as given in this graph. What is important is you're very, very safe. So remember that these patients were about 80 years in mean, 78 to 80 in mean, which means our oldest patient in the trial was 91 years old in the trial. and he had no 1-year mortality and no 2-year mortality after treatment for prolapse. So this is a very, very safe situation, and you can experience that stroke rates are 0.5 to 2%, and we also have 1-year data, which is really excellent for these patients. You can see a very high survival over 1 year and very low hospitalization rates after this treatment populations over time. And if you treat the valve in degenerative disease, the problem for the patient is solved. So you don't need permanent medication. If these patients are in sinus rhythm, which is the case in approximately 40% of the cases, aspirin, 100 milligram daily, is sufficient. No medication, no anticoagulation. If they're in atrial fibrillation, simple DOAC or warfarin is sufficient, which is also very cheap as an ongoing medication. And you can see that this is also the reduction in mitral regurgitation, in M-tier, in prolapses. So this is only degenerative disease, which is sustainable over 1 year, 2 years, and as we now know, also over 5 years. And there is also remodeling. You can see that the transmitral gradients increase with the procedures, but they stay in mean under 4 millimeters. Degenerative disease. So this significant improvement converts into clinical feeling. So New York Heart Association class and the Kansas score for quality of life are significantly improved by about 15 points, and this is also sustainable over 1 and 2 years. So this, and there is an additional registry with unsuitable cases included in the randomized trial. And if you look at the age in these non-suitable patients, it's in mean 81 years. So also here, the oldest patients were above 90 years of age. And you can still see atrial fibrillation at about 70%, effective regurgitant volume being 0.47, so really severe, more than in functional disease, and the different use of the devices. But you can see that even for this very high-risk population, 100 patients, up to 1 year, the composite adverse event rate was very low. And look at the 1-year mortality. In patients 81 years, it's only 5%, 1-year mortality. So if you do TEER, it is very safe if you have the experience and the volume, and you can translate this also in high survival, even in this registry group. So if we look around this data, we look into also the remodeling here, which is in the middle, left ventricular and diastolic volume going down from 145 to 123. Very fast, as you can see, over the time course of about 6 months, and then staying stable over time. And this again translates into about 15 points quality of life score improvement. So just to this is artificial intelligence, so there is no more tracing. The system automatically indicates where our regurgitation is. It can identify it to the different segments, and like in MR, we're now able to do volume courses, so regurgitation, integrate flow automatically by the system and identify the prolapse region in these patients. And this can also be done in pediatrics from 5 years and on in 3-dimensional echocardiography. And this is a new probe, which is the X11, and you can nicely see these images of a failing surgical valve, which is then treated with a replacement here. And this is 11 to 4 megahertz in a very, very small mini TOE, which is able to do patients 5 years to 95 years. So this shows also our registry here in the MitraClip group, which was in the MitraClip G4 group with different etiologies, and you see that mortality dropped over the range of the last about 8 years from about 5% 1-month mortality to now 0.8% mortality. And this is also true in the TEER suitable and in the prolapse group, as published here in JACC Interventions. I'll skip the Matterhorn, which has already been shown. So what is next actually is 2 trials that will be important, and we'll report this and next year. It is the Repair-MR trial, which is 70% enrolled. Primary disease, which aims for superiority of surgery against M-tier, which is very difficult to do, and these patients are 65 and older. So my take-home messages here are M-tier and DMR is approved in the European Union since 2008, in the US since 2013. There have been more than 50,000 human procedures in pure degenerative disease. The randomized trials were Everest 2, CLASP 2D, and the upcoming Repair-MR, which will report next or 2026 at 75-year-old patients, and primary MR, which aims for superiority of surgery, but which will be hard to maintain. Thank you very much for your kind attention.
Thank you for your excellent presentation and interesting presentation. So I invite you, Professor Bardeliban, to look to the
for also the next live case. It was not done at our institution, it was done in the US, so I think our co-moderator, Juan, will be excellent to co-moderate, and also Augustin, who has been an imager in these sessions. So if you can just play the video. And this shows you actually exactly the cohort C, or the additional cohort in degenerative disease, when M-tier is no option.
Stefan,
Can we
advance the slides, because exactly you will see the exactly right there.
Okay, we'll just go to the case perhaps here. Of course, a contraindication to M-tier, as you can nicely see. You see the fusion of the segment 3 in the three-dimensional images, which is very nice. There is not a predominant regurgitation, as we can see here. It's just moderate or mild to moderate. In combination with regurgitation, which was your question, is actually one of the sweet spots for the upcoming situation. Which is important in this kind of procedures is to plan these procedures by CT, as we have to look for the left ventricular outflow tract, which is very important because all these devices take some volume into the ventricular part of the mitral valve, and also in the outflow tract we have minimum distances for tendine, for instance, 2.6 centimeters diameter. You can use the gold which is higher, of course, than in TEER. And some use cerebral protection systems, so the stroke rate here is in the range between about 3 and 9%. This has to be recognized. This is the Sapphire system, which is in the hands of the Abbott cardiovascular group. And you can see it's also a single-step valve delivery, which is even easier as a technical part. A yo-yo disc, or like an occluder type. So we have a disc that is larger in the outflow tract and in the area of the ventricular part. Then you have the use of fluoroscopy, of course, and you can see that the outer stand typically has a very conformable soft stent design, while the inner stand is a little bit more rigid in order to enable valve function. Here you can see that there are different valve sizes. Here a 36 millimeter valve is above 200 millimeters, 276 to be more precise in this patient. So a very good in this situation. And if you can just play the video, I'm not sure that it's ongoing, so that we perhaps move a little bit already ahead in order of the sake of the time from the technical group, because I have no mouse here to steer the video. I can try to start it. I press the button. Can the technical team please start the video? Yes. And also perhaps already advance a little bit, that you see the major points. So if you could just this would bring us gradients of about 10 or 9 to 10, which is not what we intend to do. So we're quickly moving through the case. This is the calculation of the orifice area, which is severely reduced. It's between 1 and 1.5 centimeters to the square, as you can see nicely here. And here you see the setup. So, of course, wire in the left ventricle, which goes across the septum. You have very nicely the height which is a surgical valve implant, as we can nicely see here. And what we do now is that we introduce the pathway and do the balloon dilatation. You see the marker. To be seated and also to expand the stent frame. It's a 36 French sheath, just to give you a comparison. The Pascal system has 25 French, and this is a 36 French system. This is like the Lux valve that we may discuss later during the day when we see the new options in tricuspid. Large, but it can be done by percutaneous access. Here has been done a small cut down, and you see this valve going down. It's a venous application, so we typically use one ProGlide, one set suture, or two ProGlides. That's something, and they will not be anchored directly into the venous system, but into the perivascular tissue, actually, and help a lot to allow for control of the bleeding situation. Here you see the sheath advancing. I think this is an important step, so we have to have a situation where we can advance then later the valve, and the most critical part is, I think, the nail, so which is the stiff part, which is straight, and which has to follow the atrium, the transeptal puncture, and this also needs a certain height in order to cross versus the lateral side of the mitral annulus down. So the sheath is now being placed. We have a guidance with a safari wire, which is mainly used in these instances, which gives a very comfortable support actually for the valve to go into the ventricle, and is also very safe, as we know. And now the system will be clip system, actually, which allows for steerability.
So one of the things when we started with this program, and I'm glad we did this, is that we made a lot of emphasis on maintaining the identity of MitraClip. So operators that know how to do MitraClip, they feel very familiar and comfortable using the system. And if you see not only the architecture, but actually also the functionality, the MLA. Procedure, if you get this catheter, you immediately know what to do with it.
Okay, and we now move on to the system where we are already across the septum. I think, Juan, this is a very good point. Oh, you try to move again. You did it right. So move to the last third, perhaps, of the procedure, of the video, down there. Can you do that? So that we see you moved out, and perhaps go there and play, and then don't or do it here in the preview system. It's also here, and you can maximize the image there. Okay, and just try to play it. Yes, press first. And the beauty is that device. And this is a pullback action, so you first deploy, as we see now, the ventricular part of the occluder type shape of the Sophia valve here. So we see the control of the nose cone. The nose cone is put back max to the Sophia system. We can see the ventricular part, the apex being engaged by the curl of the wire. And now you can nicely see the interaction with the basal left ventricular muscle here in the contraction part to this part of the brim. The system is then being pulled up, as you can see here. It's a little bit like the Voc valve one, that you engage the leaflets on top of this sealing part, so they're actually engaged to the waist. Is that correct?
So it doesn't go behind the leaflets? Rather than like Evoke that actually sends the anchors behind the leaflets. You will see when it unfolds, it just creates these platter-like mechanism.
Yeah, but it's very important, of course, to have the second disc like in ASD occlusion. This is why congenital training is also very helpful in these instances. You can see here that we're touching the septum here a little bit on the right-hand side if you look at an echo. Fully exposed, and now the atrial brim is being also exposed. So we're not paying attention to details of valve morphology, but we need, of course, the landing zone, which is important, and to be perpendicular to this area. The valve is now already functioning. I think we're coming which we see here on the left echo image. And this gives us a two-chamber view and a biplane image of the outflow tract, a three-chamber view. The valve is now fully functioning, and you're retrieving the nose cone and later the wire. And I hope we will see in a second also some color images just to see valve function. And so these are very fast procedures, Juan. So having the experience of tendyne more, so we've done more than 35 tendynes, which we've seen before with Augustin, showing your Sophia system here. I think it's a very, very predictable result, isn't it?
It is very predictable and very reproducible. I mean, once you're in with the catheter, it's a 25-minute procedure. It's super simple, super fast.
So you nicely see the axis of perpendicularity. This is typically a 30-degree REO, 20 to 30 degree, and a little bit of cranial. And we get a side view here. And now the valve is fully functioning. It's like a surgical valve. And there is, Juan, also the possibility to later put a valve in valve, as the seating is very, very stable. So this is in comparison to things like the Encircle or the M3 or the High Life, etc. I think this is rocket solid.
Here, that's not a problem at all.
And here I draw your attention to the echo. Echo is very important in all structural interventions. You see this disc-like or occluder-like shape. It's like an ASD occluder with a valve inside, okay? And you see there is no paravalvular leak. The valve function immediately is supportive. And for the matter of time, I think we should stop here. Thank you.
We'll keep the discussion at the end of after Juan talks, actually, I think. It's a great pleasure and an honor to introduce my mentor, my friend, and my brother who influenced a lot my career. Juan Granada is the CEO of CRF, but also an interventional cardiologist and mainly an inventor. Juan created the Cephea valve, actually, after the death of his father to treat the mitral regurg. So he influenced me a lot to be also an inventor and key opinion leader. Juan will bring us to the future now. We'll discuss the future of the mitral regurg with the TMVI devices coming to the market. And as discussed with him before, I think the TMVI will be probably more suitable for Africa than the TEER devices. So Juan, please bring us to the future.
Thank you, Walid, and we'll talk a lot throughout the meeting, so I have to say, thank you to all of you for having me here. I'm really humbled by the opportunity and very excited about, the future. It is difficult to talk about what is coming next when, you have limitations, getting the devices that actually we need today. But I think it's also important to see what is coming into the future, so we prepare the next generation of physicians and train them on what is really needed to be able to adopt these technologies in the future. One of the first things that I want to say, and this is one thing that sometimes people miss during these talks, is that mitral regurgitation is actually a very bad disease. And one thing that governments don't realize is that it's perhaps more expensive to treat rehospitalization and heart failure, in a large number of patients that perhaps, preventing rehospitalization and improving quality of life. This is a paper, and there are many of papers of this kind, but I like it a lot because it really shows, the natural history of mitral regurgitation. Included approximately 1,100 patients with symptomatic MR and heart failure. Most of them, as it usually happens, were FMR or primary. And as usually happens in the real world, most of the patients with primary or degenerative went to surgery, 84%. In the patients with secondary, most of them actually went to medical therapy. The patients that were unoperated, that did not receive treatment, had lower ejection fraction, approximately 27%, and high surgical risk. When you see these analyses, this is pretty much the patients that are in need of transcatheter solutions. We need to put the numbers down to actually see how much money we could potentially save to the system if we select the right patients. But what is the problem? The patients that we see today, as the patient that you saw in this presentation, most of them display very complex anatomies and have limited therapeutic options. Also are very high risk for surgery. A lot of people say, mitral clip, this is gonna, solve all the issues. I wish, that was actually true. The problem is a lot of these anatomies, like this patient, are patients that are non-surgical, have a lot of comprehensive technologies. One of the things about the mitral field that is different than the aortic field is that innovation in the mitral field is driven by anatomical needs. And you will have, for example, technologies like TEER that are very sensitive to specific anatomical features. You need specific features in order to work. And theoretically speaking, on the other side, we have replacement, which is less sensitive to the anatomy because, in theory, you could put the valve pretty much in every single anatomy. The problem is in the mitral field, we have a lot of anatomical variations in between. And that's the reason why you see technology like chordal replacement, leaflet extension devices, and annular reduction that continue to develop to treat a specific anatomical problems. I am a believer of TEER. I really believe TEER, has created a revolution and a new field in our
interventional field. But one of the things that, one of the issues that I see with TEER is that it's a technique or a procedure that is absolutely standardizable. You get 100 physicians and you tell them exactly what to do and follow the steps, but it's not necessarily reproducible. Because if I get the same 100 operators, they will get results according to experience, volume, and actually patient selection. The problem is the operators and the centers need to balance between having great results with higher gradients and more device use, or less better results with more residual mitral regurgitation according to the number of clips they use. So I really think that in order for TEER to move into the future, need, as somebody was asking, better imaging-based prediction models of technical success, and Stefan actually showed us an example. Device evolution to allow use in broader anatomical variations, and ideally in the future, procedure reversibility or the ability to remove the clip in the future. Technologies already under development of this kind. And then we move into replacement with the case that is being beautifully presented by Stefan, in which promises easy of implantation, agnostic to the etiology, reliable elimination of MR, and less recurring of MR. There is an issue that we started with a dream. We're going to actually be able patient selection is very limited because the high variability of the anatomy that we see in real-world patients. And this is the problem that we had in the last 10 years. We started developing devices for large ventricle, large annular sizes, non-calcific cannulae, and low EF. We ended up actually rejecting a lot of patients because those were not the patients that we received from the trials, and we started to get a lot of rejections. But now we know what the issues are, and we know that most of the rejections, yes, are anatomical, 60%, at least 2/3. Approximately, a third is rejected because clinical reasons, because in reality, they're better served with mitral clip than with a replacement valve. And I think this has really forced, in a way, the new generation devices with different variations of the way that the valves are developed. And my prediction is approximately in 3 years, we're going to be able to have some of these devices transseptal already in the market, at least in the US and some places in Europe. So just this is my final slide, how can we address the clinical need that is needed? There's no question in my mind that the delivery method should be transseptal. One thing that is important for adaptable device designs that adapt to the human pathology and variations. They need ancillary tools to improve the success of these devices. Some of these devices. Again, thank you for the invitation, and I think we can now go into a short discussion.
Thank you, Juan, for this nice talk. We are on time, so we have probably 10 minutes of discussion. We open the discussion for the 3 talks, so we can start with the DMR one with Stefan. Any question from the audience? Salma?
Thanks again for this presentation. My question is, we also seen the TEE and intelligence artificial, and what do you think about 3D printed models, and then to really plan the procedure?
I'm more a believer of artificial enabled virtual models, to be honest. We did 3D printing, but 3D printing is costly. It is also not possible to dissect the model dynamically, what is needed if you go inside the heart. 3D printing is very nice if you have an aorta, if you have a congenital disease, to appreciate the anatomy to hold it in your hands and may be more suitable for a surgeon than actually for somebody who's looking mainly on screens and where you want to plan. So what I showed you was the first sessions of Philips, and also GE and Siemens are doing this. It's called Easy Valves. It's calling artificial intelligence-enabled automatic valve analysis. And I think this is much more the future because it costs nothing. It's just a software that you can employ multiple times, and you're able to multi-planar dissect. I'll show this today in the afternoon for the tricuspid session. Multi-planar reconstruction and analysis is much more important than simple 2D echo, and also more important than biplane imaging, what we use now in the majority of cases. As the resolution, temporal and spatial, gets up with every software enhancement, we will mainly work like in CT, live in echo. So this, I think, is the future. And also, as I showed you, to automatically analyze the regurgitation. We have all the information in the image, in the three-dimensional image. The problem in the past was that we had to manually decide what frame to use and also where to use it. So when you were looking at as echo for regurgitation, you took the single most extensive Pisa zone. But this is wrong. It's actually a continuum. It's like a Gaussian curve. You know, it starts with mild regurgitation, it goes to moderate, it goes to severe, and then it disappears again. And the integration, the area under the curve, is much more important. So we have to go to CT-like and to MR-like imaging in echo. And I think this will be the future. It's radiation-free, it's cheap, it's non-costly. A TOE probe can be used several years in thousands of procedures. So it's like reusing an Inouye balloon. This is the way to go for Africa. It's not ICE. In my opinion, it's TTE and TE. And then you will have most answers. And this is the cath lab. You don't need contrast.
And I agree with Juan, just one comment. AI is not only diagnosis now. We are working more and more for navigability, and we are working on prediction. And I hope in 1-2 years we'll come with the software telling you how to deal with your device and how to navigate your device and where we have to put your clip, what will be the orientation, the optimal orientation of the clip. This will democratize the technique actually and the approach, because people, even team with small volume, can have this tool to help them to achieve optimal results. And I'm a big believer of AI.
Professor Lehiv.
It's about vascular access, venous access. You know, for TAVI, the access is treated by CT scan, and for implantation of mitral valve, do you use some investigation for the vascular access for the venous? You know, the venous system is more elastic than arterial, but how to access the access?
You do the same. You do a venous injection, and actually you also use CT. For the main trials, we do CT for venous access, and you do a spiral. That's a fast CT. You don't need a high resolution. We simply identify that we have no kinks and no severe stenoses. This is from the jugular and can also be done from the femoral. And you're totally right. We just need a minimum diameter of about 6 millimeters. And you don't have to volume deplete also in replacement. That's also a very important thing to recognize. For Tendyne, for Sophia, etc., we don't prehab the patient like in MitraClip. In MitraClip, we want to have the heart smaller. In replacement, we want to have the heart identical to the CT scan. So this means you don't have to diurese the patients before the procedure. We actually want to have a very, very safe puncture, which is mostly ultrasound enabled. And then we go in the wire, and you're totally right, it's very dynamic. I was a skepticist for the jugular approach for the Lux valve, because I thought you will never do 40 French in a jugular access, and actually it's possible, because these patients have dilated venous systems, and they're very elastic. The only thing that we don't want to do is to patch them surgically. So cut down is definitely, I can tell you this from Apollo, I can tell you this from Lux valve, no surgical cut down. Percutaneous access and percutaneous closure. Perclose or ProGlide plus 1Z suture. That's all you need. And in jugular, you simply do a 30-degree tilt of the patient. So heads up a little bit, and then you have no bleeding in the venous system. You have no pressure there. Yeah? You close it, and you pull up the patient, and you tell him, stay in bed for 4 hours, and then you're done. Even if you do a 1.2 centimeter hole in the venous system, no problem.
Thank you.
Dr. Batir.
Thank you. My question be for Professor Granada for presentation for the mitral valve replacement. Thank you for this nice look to the future. Really, it's very nice to see. It seems to be a very nice solution for mitral regurgitation in this patient, but you told us also of problems with anatomy and difference between patients. So I'm thinking about the mitral ring. I know that the mitral ring is different from patients, so is this technique different or maybe can interact differently by the shape of the mitral ring? Is there difference between patients? Is it source of mitral regurgitation after valve implantation? And my second question will be about interaction between the valve and the septum. Is there any risk of AV block in these cases after valve implantation?
Is the second question? AV block. Oh, good. Very good question. So, just to be brief, the low eligibility rates in the trials were not really related to poor design of the valve, but is because when the field started, the idea of the patients that we wanted to target is actually different to the patients that were really needing the type of technology, which were MAC cases, mixed disease, small ventricles. These valves at the beginning were designed for because on the history of development of these devices, there was this battle, this fight between you have to be D-shaped or you have to be circular. And some companies went D-shaped, some companies went circular. I'm not really saying that there is important difference in the future, maybe there will be differences, but these designs are so adaptable and they're so conformable that even if it's D-shaped, the external frame deforms to the anatomy. Applications, you know, is interesting because of in all the series, you put all the series together, AV conduction systems are not really common, at least for TMVR. I have to tell you, we've done almost 50 cases with Cephea. There's only one patient that required a pacemaker, and we don't even know it was related to it because the patient had underlying, electrical issues. And if you look at Tendyne and Intrepid, everything is not common. You do see once in a while bundle branch, changes, but it's not as common as you see in TAVR.
Can I have a question for you? So, guys, I'm asking you as probably PIs. Both of you are PIs of the most important TMVI trials now. Do you think that a country as Tunisia, having a bunch of patients with mixed disease, perfect patient for TMVI, be part of first in human EFS in the future? Is it possible?
Look, I have personally taken, technologies to areas that actually do not really have, I would say, the infrastructure, to do this, and it's absolutely possible, but you need very strict standard operating procedures. You have to have very good imaging protocols. You need to have very good data transfer, platforms. And the most important thing is you need to have a good heart team. Yes. It's not one person. It's a group of people that work together, because when things go south is when you actually need to have a good surgeon to go and help you. When you actually are struggling with imaging, the imager has to stand up and help you. So ICU care,
if you look at the TMVR trial, you know what is the main issue? It's not the procedure. It's actually the follow-up care.
Exactly.
It's having the right people taking care of the patient in the ICU. But it's absolutely possible.
Absolutely, but what we also have to see, I think the infrastructure in Tunisia is already highly elevated, especially in the coronary field. So this is one of the prerequisites. As I'll give this afternoon, only need an interventional cardiologist or only a surgeon. This is wrong. You need a multidisciplinary team. You need a good cath lab or hybrid OR, but this is not the decisive point. You need the right persons trained in these rooms. It's not about the rooms. It's about the persons having experience, having knowledge about interventional procedures, about imaging, both CT and echo. It's much more important than MRI in the beginning, and to follow standards, as Juan pointed it out. It's very important to be precise, strict, and I wouldn't say German, but I would say, because I was late in one of our meetings, but I would say that you have the belief that if you want to do it, you do it. Yeah. And you follow procedures, and that you have not only hierarchy, but also a team where all team players are respected. And I think this is very, very important. As Juan pointed it out, the patient care doesn't end in the hybrid OR or cath lab. It is also the knowledge of the physician on the ward. May it be the intermediate care unit or may it be the normal valve unit, because if he doesn't get his anticoagulation, if the person is not able to tune up the warfarin or whether you take a DOAC, etc., this is also important. So it's the whole care. The weakest part of the chain breaks the chain. So I think that's the most important part from my side.
Yeah, exactly.
So, closing comments? I think that we... Oh, go ahead.
Another question is surgery, famous surgery.
As a cardiac surgeon, I would like to ask the panel, what will be the future of cardiac surgery in the next 5, 10 years? And how can we teach our future cardiac surgeon to do this? Can we call them cardiochirurgo, like the Italian call them, or can you call them cardiac surgical something?
Yeah, it's a very nice question, actually. It's difficult because we are not a big group as a surgeon doing this procedure, and we are fighting every day to convince our dinosaur community to understand the need to train surgeon to this procedure. I think that a surgeon and a heart team is very important, not just to fight to not send the patient to the interventional cardiology site. It's very important to be part of the decision-taking process. It's very important to be in the room because we are thinking differently and we are seeing the anatomy differently. If I do the case with Stefan, with Juan, they have this approach to see the mitral valve as an image in the echo. We saw the mitral valve times and times. We repaired this valve. We understand the chordae anatomy. So it's very important that the surgeon is there because there is an additive value. The surgeon also have to be there following the patient. The problem is, and even in Canada, it's very difficult. I'm fighting every day to convince my resident to come to the hybrid room because their mind, the surgeon is here just for complication. No, the surgeon is not here for complication. The surgeon is here to do the procedure, to think, and to be the partner. This is the most important word, partner. You have to be the partner. When it went badly, the cardiologist knows that he has a partner. He will support him in addressing the complication. To train, this is very important. We are trying in Canada to have, how to train the resident, but we can talk later if you want.
So just 1 minute for the closing comments. The future of the surgeons is absolutely bright.
just need to embrace the changes. And for us, I would actually break this final discussion into three components. You know, one is the device. I don't think everything you saw today, there is no perfect device that can treat all the patients. That's the first message, because all these technologies have advantages and disadvantages. In terms of the operator, it's extremely important that we stop thinking about one person and start thinking about a team, because otherwise you will not be able to really do these or any other procedures. So the creating this environment of a team is absolutely key, especially on imaging and actually also embracing the surgeons. And third is the patient, because at the end of the day, we need to make sure that we are benefiting the patient, and patient selection is one of the most important things. Choosing the right patient that could benefit from the right approach. And I have to tell you, if the patient is a good surgical candidate, is good at good surgical anatomy, should go for surgery. And I think that's the most important thing. Thank you again. This was an unbelievable session. I really enjoyed it and learned a lot from all of you. So thank you for staying here, and let's go to the next session.